Well, hello, friends. I'm Dawn Johnston, Director of Development for the Providence Brain and Spine Institute. And on behalf of the Institute and all of us at the Providence St. Vincent Foundation, thank you for joining us today. Today's presentation, It's Brain Surgery, Not Rocket Science, is part of a virtual series called DocTalks. These presentations bring our best and brightest clinicians to you, so you can learn about some of the innovative ways we're delivering care to our community at Providence. I'm honored to work with Dr. Deshmukh and his colleagues at the Brain and Spine Institute to ensure that they have the resources they need to provide the very best care possible for many years to come. I know many of you on the call today have invested in the work we do, and we're grateful to you. Thank you. Before we begin today's program, I wanted to share a couple of housekeeping items with you. We wanted to keep today's program brief since many of you spend a lot of time on virtual calls these days. Dr. Deshmukh has a 25 to 30-minute presentation with about 15 minutes for Q&A at the end of the program. To ask a question, just use the Q&A tab at the bottom of your screen. We might not get to every question, and if we don't get to yours, we'll follow up with you after the program. And if you have a question after today's program, please feel free to shoot me an email. Today's program is being recorded, and we'll be sharing the link to that recording with you in a follow-up email. So be on the lookout for that in the next couple of days. Now I'd like to take a few minutes to briefly introduce Dr. Deshmukh. Dr. Vivek Deshmukh is the medical director of the neurosurgical program at the Providence Brain and Spine Institute and co-medical director of the Institute. Dr. Deshmukh received his doctorate of medicine with highest honors from the University of Florida in 1998. After completing fellowships at Barrow Neurological Institute, including advanced work in cerebrovascular neurosurgery, Dr. Deshmukh became the director of cerebrovascular and endovascular neurosurgery at George Washington University in Washington, D.C. In 2010, Dr. Deshmukh and his family made their way out to Portland. In addition to his surgical and leadership commitments to the Institute, Dr. Deshmukh has over 100 publications and oral and abstract presentations. His presentations and publication work include work in the surgical and endovascular management of intracranial aneurysms, vascular malformations of the central nervous system, minimally invasive approaches to skull-based tumors, and innovative surgical approaches to the lesions of the brainstem previously deemed inoperable. Dr. Deshmukh has been recognized as one of America's top doctors by Castle Conley and one of the top doctors in the Portland metro area. We are so lucky to have him at Providence. Thank you for joining us today, Dr. Deshmukh, and I'll hand it over to you.
I'm going to go ahead and share my screen. Can you hear me okay, Dawn?
I sure can. Thank you.
Great. Thank you so much, Dawn, for those kind words. And thank you, everyone, for joining us today. It really is an honor to speak to you about the latest advancements in neurosurgery. And, I liked Dawn's idea for the title. Certainly, brain surgery and rocket science have a lot in common. They're both challenging, delicate, intricate, and with very little room for error. But I think the biggest difference naturally is that neurosurgery, we deal with people, and that makes it infinitely more interesting to me. And so today, we'll give you an overall perspective on what we're doing in neurosurgery at Providence Brain and Spine Institute. And neurosurgeons really take care of patients with stroke, brain tumor, patients with epilepsy, movement disorders, and spinal disorders. And when you think about stroke, there really are two types of strokes. There's the ischemic stroke, where there's a lack of oxygen from a blocked blood vessel that leads to the brain, and that can lead to permanent brain damage. Or the second type of stroke, which is known as hemorrhagic stroke. And that is a case where you have a patient with bleeding into the brain as a result of a blood vessel malformation or an aneurysm or weakened blood vessels as a result of aging or high blood pressure. And so two very distinct things, but often used quite interchangeably. And for neurosurgeons, what we do is prevent and treat patients with stroke. For patients with blocked arteries, we reopen them using stents and bypass surgery. For patients with brain aneurysms, we use surgical techniques to repair the aneurysm before it ruptures, or use less invasive techniques to achieve a similar goal. Neurosurgeons also take care of patients with brain tumors, and there really are two big categories of brain tumors. There's the benign and the malignant. So the non-cancerous and the cancerous. And we take care of, unfortunately, one of the most deadly disorders known to man, which is known as glioblastoma, where the average survival is only about 15 months after, despite surgery and radiation and advanced chemotherapy. And I'll talk to you a little bit more about the opportunities we have in taking care of that patient population. We also take care of patients with epilepsy, and epilepsy is a result of an abnormal discharge of electrical activity in the brain. And that electrical activity then spreads very rapidly. The brain is an electrical organ after all. And so if you have an abnormal focus of electrical activity, that can lead to epilepsy, which manifests itself as shaking disorder. And then eventually, if it spreads or becomes generalized, can lead to a loss of consciousness and can be life-threatening in and of itself. We also take care of patients with movement disorders, such as Parkinson's disease and essential tremor. Parkinson's patients are generally older, and what they have is a difficulty with movement. It's a movement disorder where their movements are slowed, their walking is slowed, they become what's called bradykinetic, their movements are stiffened, and they have a tremor that they have difficulty controlling. And I'm excited to say that we have a neuromodulation or functional neurosurgery program in place over the last 4 years, where we take care of these patients with movement disorders under the excellent leadership of Dr. Seth Oliveira, who's our director of that program. It may surprise you to know, in fact, that most of what neurosurgeons do is treat spine disorders. That's actually the most common disorder that we treat as neurosurgeons. Now, many of us are subspecialized. For example, I do mostly blood vessel surgery for the brain and the spinal cord. And Dr. Gore does mostly brain tumor surgery. Dr. Oliveira does movement disorder surgery. But most neurosurgeons actually take care of spinal disorders, such as herniated discs, pinched nerves, slipped vertebra, resulting in back or neck or leg pain. So this is kind of an overview of what neurosurgeons do, but really the focus of my presentation today is to share with you advancements in neurosurgery. And in paying attention to this, just remember that the things I'm describing for you, we couldn't do 5 years ago, which is just an amazing statement to make for neurosurgery, but indeed it's true. I'll start with brain aneurysms. We know that an aneurysm is a blood vessel malformation, an abnormality of the blood vessel, I should say, an outpouching, a weakness in the blood vessel wall that results in a ballooning of the artery, and it's a weak spot. And naturally, a weak spot in a blood vessel in the brain can rupture. And as you might imagine, a ruptured aneurysm in the brain is a life-threatening, catastrophic, life-altering event. And this illustration shows you that what patients with aneurysms are missing, in the segment of the aneurysm, they're missing the muscular wall of the blood vessel. It's interesting to think of blood vessels as having a wall, but indeed they have a fairly thick wall with a very robust muscular layer. And in an aneurysm segment, that muscular layer is missing, and it's very thin walled. And the problem with that naturally is it can rupture. And as I mentioned, with a rupture, about half the patients die from a ruptured aneurysm. And of the survivors, half of those are permanently brain damaged. So that's a catastrophic event. And our goal really is to treat these aneurysms before they rupture. And the fortunate patients where we discover them, frequently it's a patient who gets an MRI for a headache, or an MRA is blood vessel test that it's called. And we see the aneurysm and we're able to repair it. That's really the best case scenario. Too often, however, we see patients coming in through the ER with a ruptured aneurysm, and if they've survived their original bleeding event, then we're able to stabilize them, get the aneurysm secured, and get them through that period of time as the blood in the brain dissipates. In general, there are two main strategies to treating brain aneurysms, and they couldn't be more opposite, really. One is open brain surgery, and the other is a less invasive technique. And open brain surgery involves an incision in the scalp, removing a small piece of bone just above the eye, typically, depending on where the aneurysm is located. And then we go through natural clefts in the brain. We don't actually go through any normal brain tissue to secure an aneurysm. There are natural clefts or fissures that we go through. And then we find the aneurysm, expose it circumferentially, and then repair it by applying a titanium clip across the base of the aneurysm. That essentially excludes blood flow into the aneurysm. And if there's no blood flowing into it, then it can't rupture. This is a very effective and durable treatment. It's been around for decades. I've done over 1,000 of these just to show you how common they are, and a very effective treatment. And still, I would say, in many ways, a mainstay in the care of the aneurysm patient. But over the last 20 years or so, we've seen a rapid advancement in the less invasive technology, the less invasive treatments for intracranial aneurysms, which involve a tiny little puncture, smaller than the tip of my fingernail, at the top of the right femoral artery, at the groin crease, at the top of the right leg. Working through that tiny channel, we take small catheters, thin plastic tubes, navigate them through the blood vessels into the aneurysm segment itself, and seal the aneurysm with platinum wires called coils. Sometimes we use mesh tubes to keep the coils inside the aneurysm and keep them from falling out. And that excludes that aneurysm from the circulation. If blood can't flow in, then it can't rupture. This has been a remarkable advancement in neurosurgery. It has changed the landscape of what we do. And in fact, now neurosurgeons essentially always come out being able to do both the less invasive kind of radiology-driven techniques and the open neurosurgical techniques. Even within the field of endovascular, every 6 months to a year, we've seen remarkable advancements. And this technology here that I'm going to show you an animation of just became available through the Food and Drug Administration about 2 years ago, a year and a half ago. And we've used it with great success here at Providence Brain and Spine Institute. It's called a web device. It's essentially a basket made out of a nickel and titanium alloy that is deposited into the aneurysm. Rather than sequentially putting in smaller and smaller coils to seal an aneurysm, you put one device into the dome of the aneurysm and reconstruct the blood vessel wall in that fashion. It disrupts the flow of blood inside the aneurysm. So here's this animation. You have an aneurysm at the top of this artery here, and that's naturally a weak spot. We take a tiny catheter, remember, all through a small incision at the top of the right leg, and deploy this web device inside the aneurysm, and that excludes it from the circulation. And what this has allowed us to do is treat aneurysms at these branch points. You see this branch point here, which we couldn't take care of 5 years ago with the coils or the stents, and these patients often would need open surgery. And now we're able to go in with the web device and seal the aneurysm shut, allowing us to kind of expand our portfolio of patients, or our category of patients that can benefit from this treatment. And one perfect example was a recent patient that we helped with this device. There's a 48-year-old male who was watching TV, sitting at home, relaxing, and developed an explosive, sudden onset worst headache of his life, accompanied by nausea and vomiting. He was rushed to our emergency room, where he was stabilized in the ER, brought up to the intensive care unit. He had an aneurysm deep inside his brain, one of the most challenging aneurysms that we as neurosurgeons face, called the basilar apex. It's essentially at the center of the brain, and to reach it I would say, a hazardous surgical treatment in many ways. One that I've done many times, but there's a risk that comes with that. And so this particular patient, now you have a ruptured aneurysm deep inside the brain that is difficult to access, difficult to get to, and surrounded by tiny little branches that go to his midbrain. The midbrain is a part of the brain that controls your level of consciousness. So if we lose even one of those tiny little branches, the patient may not wake up from surgery. And so our goal was to treat him less invasively so we wouldn't have that potential complication. And 5 years ago, we couldn't have done this. 5 years ago, we would have had to take him to surgery and repair it with the open surgical techniques. And now, just last week, one of my colleagues, Dr. Thiesing, very skilled neurointerventionalist, used a Webb device and was able to exclude that aneurysm from the circulation. The patient was discharged home within a week after a ruptured brain aneurysm. Really a remarkable technology. He was sitting up in bed the next morning, eating breakfast and having just a normal conversation with me. It's quite amazing to take one of the most dangerous aneurysms that we neurosurgeons face and treat it less invasively and be able to get that patient on their road to recovery is a remarkable advancement. And again, we couldn't have done this 5 years ago. One of my most gratifying cases, I would say, is the patient that we can treat with a blocked blood vessel in the brain. So these are patients with what's called acute ischemic stroke. So patients that all of a sudden develop inability to speak and inability to move one side, paralysis on one side. They're rushed to the emergency room. Sometimes they need a breathing tube placed to stabilize them. It's really kind of a catastrophic, life-threatening event. And on their imaging, we can see a blocked artery in the brain. So there's no oxygen going through one of these major blood vessels in the brain. And so what we're able to do is take these patients to the cath lab, the angio suite, insert a small catheter at the top of the right leg, navigate this plastic tube, this thin plastic tube that you see into the blood vessels that lead to the brain, take an even smaller catheter and wire into the actual clot that's obstructing oxygen from flowing to the brain tissue. And we navigate through this very carefully, and we deploy this device that then secures and enmeshes itself within the thrombus, this clot that's obstructing oxygen. And remember, these patients are on the table, unable to speak, unable to move the right side, paralyzed on one side. We deploy the device, we extract the clot, we see immediately extra blood flow, normal blood flow resuming to that part of the brain. And the result is really that dramatic. One moment, there's no oxygen to that part of the brain. And within seconds after we place this device, you see normal blood flow again. And as I mentioned early on, this is one of the most gratifying procedures I do, because you have a patient who's paralyzed and unable to speak, and immediately on the cath lab table in the angio suite, as soon as you extract this clot, they start talking to you and they start moving that extremity again, both sides, that limb, upper and lower extremity. And it's just amazing as they're being wheeled out of the angio suite to see that they're essentially back to normal. And so a remarkable advancement. You know, we couldn't have done this 5 or 10 years ago with such great ease. And it's made a tremendous difference in the care of the stroke patient. When you think about stroke and how disabling it is the leading cause of disability in the United States. It was the third leading cause of mortality or death in the United States, but now that's going down. In fact, now it's the fifth leading cause. And I think that effort that we've made in advancements in endovascular technology, advancements in clot busting medications, resulting in fewer patients dying from stroke. So we're making a big difference with these patients. The next generation of care really is about protecting the brain. So when you think about a patient with a blocked blood vessel in the brain, they've only got minutes, perhaps less time before you start seeing irreversible brain damage. In fact, the mantra is, time is brain. The seconds do matter in these interventions. We track how quickly our team is coming into the hospital to the second. And really what we're trying to do is get them treated as quickly as possible. But what happens when a patient doesn't have that reserve? They've got a blockage in the brain and they don't have other vessels coming in to help out. Well, that brain tissue dies. Well, what if we could protect that brain until we get that blood vessel opened up? And this is what we're engaged in here at Providence, one of only a handful of centers in the world, participating in a trial with a medication, a peptide, that is crucial at minimizing brain damage until you get the blood vessel reopened. We know from our basic science research, a molecule known as nitrous oxide can lead to brain damage in these situations. And with the blockade through this peptide, we actually see that we're able to preserve that brain tissue until we get them into the angio suite and get that blood vessel opened up, minimizing the amount of brain damage, maximizing the patient's recovery. This is really the holy grail, so to speak, of a neurovascular treatment of stroke. And so exciting to think that now we have a peptide that can really make a big difference. And we're doing a clinical trial here to demonstrate that. With epilepsy, if you had a patient where you could identify a focus of seizures, so, okay, the seizures are coming from this spot in your brain. If we go in and take that spot out, you're going to be seizure free. 5 or 10 years ago, we would have to offer them open brain surgery, an opening in the skull, and we would resect that part of the brain. We would take out that part of the brain, often the entire temporal lobe if we're able to. That's a very effective surgery, but also invasive with prolonged recovery time. And sometimes the patients would even have some cognitive issues from removing that much brain tissue along with the epilepsy focus. Now we're able to, my colleague, Dr. Oliveira, through a tiny little incision and a tiny opening in the skull, it's less than a centimeter in size, he's able to place a laser electrode into that area where you have the focus of the epilepsy. And using heat and at the tip of the laser, he's able to ablate or destroy that part of the brain tissue that's generating this abnormal electrical activity and causing these disabling and crippling seizures. And the patient goes home literally the next morning from the surgery and is back about their business pretty much right away. In fact, this patient that we're showing you here went back to bowling 2 days after her surgery and cured of her epilepsy. Just an amazing advancement when you think of how we went from being maximally invasive to minimally invasive and precise to getting that patient back to their life right away and curing them of their disorder. And now we're using laser treatment for tumors. Same perspective. Here you have a patient in their late 20s with a tumor in the brainstem. The brainstem is the most vital and crucially important part of the brain. It's the relay station. All your impulses and messaging from your brain going to your extremities goes through the brainstem. And often this is considered tiger country. We're really not supposed to do surgery in the brain because it's too risky. There's too many important critical functions such as respiration and cardiac function. All of that is located in the brainstem. And so here you have this patient in their late 20s with a tumor from within the brainstem who's been told time and time again this is inoperable. Well, he came to our institute, met with Dr. Oliveira, and in fact, we can use laser treatment through a tiny opening in the skull. When you have such a very small electrode, you can pass it into the brainstem without any harm. And then using heat and the laser treatment, he destroyed that brain tumor within the brainstem itself, but preserving the surrounding brainstem tissue completely. And this patient has survived years now, doing very well from this surgery. And to think that he was told that he had an inoperable tumor, and now we're able to treat it with very minimally invasive techniques with minimal recovery time is again a remarkable advancement. Another demonstration of what we're able to do now that we couldn't do 5 years ago. Patients with Parkinson's disease, and this says tumor, but really it should say Parkinson's. Patients with Parkinson's disease, we are able to place an electrode into a specific part of the brain and stimulate that part of the brain to treat their symptoms. And these are really quite amazing stories. Patients who couldn't walk, had a disabling tremor, couldn't open the door to their house with their keys. And now with this treatment, deep brain stimulation, 2 tiny electrodes using this image guidance system, which was made possible, I should say, through Foundation. So thank you for that. And for all the people that supported this. We're able to identify that nucleus, and Dr. Oliveira is able to precisely implant this electrode right to that spot. If you're off by a millimeter, the technique doesn't work. So you need sub-millimeter accuracy for this to be effective and safe. And this technology, this navigation, essentially GPS for brain surgery, maps out these nuclei for us, and we can go right to the spot where we need to go. And really, I think the overarching theme for this presentation is less invasive neurosurgery. So the concept of bloodless surgery or surgery without an incision seems to be the stuff of science fiction. Well, in fact, we're doing it today. And that's what these cases are a demonstration of. This is a perfect example. This is a patient in his mid-20s who's a fisherman, lives on the coast, and came in with this massive tumor compressing the brainstem rising from the base of the skull called the clivus. And when you look at it from the side, you'll see the real kind of involvement of these really important structures with this tumor. So this is looking at it directly from the side. Here's the patient's face, and this is the back of his head. The tumor is arising from the bone at the base of the skull and crushing his brainstem. And we're just talking about how important that structure is. He was having trouble walking. He was ataxic. He was having trouble swallowing because a lot of the cranial nerves are there. So in 10 years ago, we would have had to subject him to open brain surgery, risky. We would have had trouble peeling this tumor off the nerves. It would have been invasive. The recovery would have been prolonged. Now we can do this without an incision. And you ask how? How is that possible? We can go in through the nose, through tiny endoscopes, drill this bone back here, and resect the tumor all through the nose. This is my colleague, Dr. Gore. It's just remarkable at this technique, along with his ENT colleague, Dr. Etzel Kim, and others. They're able to go in through the nose and completely remove this tumor and get that patient home in just a few days after surgery, complete recovery. He still remains tumor-free several years out. And so it's just a remarkable advancement to be able to do that less invasively is amazing, essentially without a visible incision. And when in years past, it would have required maximally invasive surgery. So, as a neurosurgeon, the hardest thing for me, is to be faced with problems where I don't have a solution, where I don't have an answer. What you may ask, well, what are the problems we can't fix now? And the problem that I think in many ways is most challenging for us is malignant brain cancer, glioblastoma. When you think about average survival with glioblastoma, it's still on the order of 15 months or so, even with surgery, radiation, advanced chemotherapy, even with the best surgical techniques. We have a long way to go with brain cancer, and I think we can definitely make a difference. What we need to do is collaborate more closely with our Providence Cancer Institute colleagues who use immunotherapy to treat cancers in amazing ways. And I know we can do this and make a difference. When you think of patients who've already had a stroke, how do we regain function? And I think there's great potential here in patients who've already suffered brain damage to be able to employ regenerative techniques. And I would like us to be at the forefront of this over the coming years. Or when you're faced with patients with crippling, disabling spinal disorders, How do we treat them with less invasive techniques and get them back to work, get them back to their life quickly? And I think spinal robotics is going to change the way we do this. So much so that I would say 5 years from now, most of the spine disorders that we treat are going to be done outpatient rather than in the hospital. And critical to our ability to achieve this is really advanced technology. There's a saying, in neurosurgery, you're only as good as the technology that you have. So we have to keep up with the technology so that we can offer our patients the best treatment and the best possible outcomes. And we have to expand our research efforts through an innovation center where we can develop the new surgical techniques that are employed to treat patients with incurable disorders. And we can train the next generation of neurosurgeons. We're already doing this. We have a fellowship for the neurovascular program. We're training the next generation, but I know we can do this for the functional neurosurgery program and for brain tumor. I know we can do this at Providence because we have, and this may surprise you, the largest volume of neuroscience patients in the state. We're the biggest neuroscience brain and spine program in Oregon, and one of the biggest in the Pacific Northwest. We're also connected across the 7-state Providence system by a single electronic medical record system. So we have data at our fingertips that no one else has, not Johns Hopkins, not Stanford. No other quaternary care center of excellence has this kind of information at their fingertips. And that means that we have great potential to make a difference for patients. But why do we want to innovate? Why do we want to be the center that innovates? And it really boils down to, we owe it to our patients. We owe it to the 72-year-old patient who is a neighbor of mine and has Parkinson's disease that's advanced. And there's no surgery or medication that's working anymore. And he and his wife are driven to depression and despair because of that. We owe it to that person to make a difference with research. We owe it to the 47-year-old female who is a mother of 4 and has had malignant melanoma. And we did 3 brain surgeries to take it out. It had gone to the brain. We treated her with advanced immunotherapy, radiation treatments, and she succumbed to her disease. She died from it 18 months ago, and I was invited, unfortunately, to her funeral. And we owe it to the 55-year-old federal government employee that we just took care of a few weeks ago, who came in with a massive stroke on the left side of his brain. We couldn't reopen the vessel. The brain damage had already occurred. And now he's left with aphasia, inability to speak, and inability to move his right side, paralyzed. 2 young kids and a wife at home, looking at a lifetime of disability. And that's the hardest thing, I think, for me as a neurosurgeon, is to be able to look at patients like that and say, there's nothing that I can do for you. And I think through our research efforts, through the Innovation Center, I want to get to a place where we say, yes, we can help you. And not just that, but yes, we can cure you. Thank you so much for your attention.
Thank you, Dr. Deshmukh. That was very inspiring. During the course of your presentation, we've had a number of questions, and so I'm going to start our Q&A. For those of you who are on the call, if you have a question, please feel free to add it to our chat. The first question is about intervention in the cath lab. So we have a question that says, when doing the intervention in the cath lab, is the patient still within the window protocol of 3 to 4 hours of last known well, or can this intervention be done at any time after a stroke?
So absolutely. You know, it depends on what their perfusion imaging shows. So if they have good collaterals, which means other vessels have kind of taken over to help keep that brain tissue viable, then we can treat them out to a day, even 2 or 3 days out from their original injury. And we couldn't do that 10 years ago. And now we have technology that can identify those patients that have this part of the brain that's at risk for permanent brain damage, but is still functioning at a very low level, still getting enough oxygen to survive, but not still resulting in symptoms. We can take them up to the angio suite and get them reopened and bring that part of the brain back. So with perfusion imaging, there is a subset of patients that we can treat even out to 24 hours or beyond.
That's amazing. Thank you. We had another question. First, a comment. Remarkable advancements. While overwhelmingly it seems a positive outcome to have patients able to leave shortly after the Webb technique for an aneurysm, do you think that there are any risks by not having prolonged patient aftercare, such as a subarachnoid hemorrhage side effect?
So the good news is with these less invasive techniques, they're not risk-free, but the majority of complications tend to happen within the first 24 hours. So we watch them in the intensive care unit overnight after the procedure. If they're doing well the next day, then they really are out of the woods. Now, there's a small chance they could have what's called a thromboembolic complication, a mini stroke, and that sort of thing, but it's exceedingly rare. And so most patients are discharged home by the next day, late morning, early afternoon, with a very low risk for a delayed complication. The patient that I described earlier with the ruptured aneurysm that was discharged home a week or so after his subarachnoid hemorrhage, we did a repeat angiogram to confirm that the aneurysm was completely secured before we discharged him. So I think, he's in great shape. So we always, for these ruptured cases, we want confirmation that the aneurysm is completely sealed. And it's true with the Webb device, you may not see that with an unruptured aneurysm right away, but it's an unruptured aneurysm. You have a little bit of time for that Webb device to heal that interface between the aneurysm and the normal artery wall.
Okay, thank you. Another question, if there were no technological limitations, what do you think is going to be the true preventative solution for ruptured aneurysms? What is the next generation solution?
So prevention of ruptured aneurysm still boils down to the basics of blood pressure control and tobacco cessation. Those are the two primary risk factors for aneurysm growth and rupture. So aneurysms are congenital lesions. Patients are born with that weak spot that I showed you in that illustration. Then they grow over time as a result of high blood pressure and cigarette smoking or just aging. And those two efforts, if we can do better with tight blood pressure control and get patients to stop smoking altogether, you would see a remarkable decrease in the number of subarachnoid hemorrhage patients, without question. But it's not a problem that we're going to be able to completely solve through prevention, because unfortunately, with aneurysms, most patients don't know they have it, an aneurysm. They're walking around, and then for the most part, unless they get an MRI for dizziness or headache, they don't know they have it until it ruptures. And so it's not a problem that we're ever going to be able to say, one day I envision a time when there will be no more subarachnoid hemorrhage patients. I don't, I see that as being challenging because of the nature of aneurysm, which is they're congenital, they're present from birth. But certainly we can prevent it.
Okay, thank you. What are you most excited about right now in your work?
So, for my work as a neurosurgeon, it's really these less invasive techniques and being able to offer patients kind of the breadth, the entire spectrum of treatments, from more invasive treatments that are more durable to the less invasive techniques where they bounce back and go back to work. I love doing brain surgery. The anatomy is incredible. There's nothing more gratifying than doing that from a perspective of, challenging, interesting, intricate, and delicate, perspective. The less invasive techniques, are rewarding in different ways. To be able to see a patient wake right up from surgery, to be able to see them walking in the hallway later that evening after surgery and going home the next morning and back at work in a week. It's incredibly gratifying for me as a surgeon.
Great, thank you. I see a follow-up question to your last question, so I'm going to answer that one next, or ask that one next. And the question is, when you say tobacco cessation, is that the same as nicotine? And does nicotine cause aneurysms?
Yeah, so I think that altogether, nicotine and tobacco, both of them, I think, are involved in this development of aneurysm. So nicotine replacement is less risky than smoking a cigarette, right? But I think both of them are kind of involved in that process of aneurysm growth and rupture. So what I tell my patients is I'd prefer you be off of nicotine altogether and quit tobacco altogether. There's certainly something in tobacco smoke that's even worse, and the most dangerous as far as forming aneurysms. But ideally, you'd be off of both substances.
Okay, great, thank you. Would you recommend cath intervention even when giving TPA? Isn't the patient at higher risk for bleeding, or would you withhold TPA?
So TPA is the gold standard for treatment of patients with large vessel occlusions, small vessel occlusions. If they meet the criteria, I would give it. And the reason is it's very low risk for us to intervene even when the TPA is on board. It's a very powerful clot busting agent, but what we do is less invasive. The incision is tiny, and the arterial puncture where we get in to do the procedure, we can seal that at the end of the procedure and keep it from bleeding. So very low risk whether or not TPA is on board.
Okay, great. It looks like there's a couple of questions in the chat, so I'm going to ask those as well. You mentioned research around cerebral protective agent for stroke. Are there other research studies you're excited about?
I think the next thing is really the next generation of devices. It's amazing this field. Every 6 months to a year, we have new devices coming down the pike for treatment of aneurysms, for treatment of stroke. And what I'd like to see is us engage more in clinical trials that go into setting up that technology as a gold standard. So really engaging in clinical trial research around technologies that we can use for therapeutic options, not just for stroke, not just for aneurysms, but Parkinson's, and hopefully someday Alzheimer's, among other disorders.
Okay, thank you. What are the interactions and counter interactions for deep brain stimulation for Parkinson's? When do you use these types of these techniques rather than medication?
So the patient has to have the classic symptoms. So the reality is it's not as cut and dry as patients have Parkinson's, because often what they have is other symptoms, and those patients are called Parkinson's plus patients. So they have this typical Parkinson's symptoms, but then they get low blood pressure when they stand up, or they have these other symptoms that sound like Parkinson's, but are really something else. So you have to differentiate the two. And that's where our movement disorders neurologists are so fantastic at pinpointing the classic Parkinson's patient who has the classic criteria. That's the first step. And in general, if the symptoms are managed with medication, then I think it's reasonable to treat with medication. But if you start noticing that the symptoms aren't well managed, or the medication dosage is starting to go up, then I think getting the surgeon involved early is really critical, and our neurologists do a good job of that. You don't want to reach a point where they've progressed in their Parkinson's and they've lived with these side effects of the medications for years and years. That's the problem. The crux of it is the medications do work, but they can have very profound side effects. Mm-hmm. And DBS doesn't necessarily cure Parkinson's, but it really allows you to treat it in a way that minimizes the symptoms or mitigates the symptoms, and allows you to come down on that medication dosing so you don't have those profound side effects.
Okay. Thank you. So there's a question about specific to the procedure for Parkinson's. What is the expected cost, and do insurance providers normally cover that expense?
Yeah, so I don't know the actual cost from a, what the patient is billed perspective. These technologies are very advanced and the equipment we use is very expensive. So I'm sure that there's a significant cost associated with it, but it is covered by insurance, including CMS or Medicare. And so these are patients, these are very established treatments and very effective treatments that are covered by insurance companies for patients that meet criteria.
Okay, thank you. It looks like we have a couple more questions in the chat. So I've got just a couple more for you, and then we're probably going to need to end our presentation. Providence ED may be on ambulance divert. Would it be reasonable to insist on being taken to a Providence ED if experiencing a stroke or aneurysm symptom?
Yeah, I would urge you to go to your nearest emergency room. That's really the most important thing. And this is what we, as I mentioned before, this is what our focus is early treatment. And the first step in that is early diagnosis, right? Unlike a patient with heart attack, where you can establish that diagnosis in the field, they can do an EKG in the field and they know this patient's having a heart attack. Stroke is often, there are things that mimic stroke, like seizure and intracranial bleeding. So really you want to get to your nearest emergency room quickly so that they can, every ER can do a CT scan. Almost every ER can do a CT angiogram, make the diagnosis, and then get you to a place that has a bed that can do what we do, which is, there's not every hospital can do that, but certainly the key is getting you to that tertiary level care as quickly as possible, but making the diagnosis first and getting you stabilized first is vitally important.
Okay. Let's see here. I had seen another question. What Parkinson's symptoms can be alleviated by deep brain stimulation?
I think the most profound is really the two that are most remarkable is the tremor and their walking. So the tremor and the bradykinesia, their ability to, they go from struggling to carry out the basic activities of daily living to getting up and walking down the hall essentially normal again. It's really quite remarkable, but I think that's what's most amazing to me.
Okay, thank you. And I see a question from Billy. Billy, I'm sorry if I'm getting your question wrong. You want to get on the Parkinson's list. I'm not sure what you mean by that. So if you would help clarifying that in the Q&A right now, I'm happy to ask that of Dr. Deshmukh. For all of you who are patients of Dr. Deshmukh's and you're on the call right now, I'm seeing your wonderful comments in the chat. And while we don't have time to go through them, I'm going to make sure Dr. Deshmukh sees all of these. It'll make his day. I see your comments from Craig and Robert. I'll make sure Dr. Deshmukh sees all of these lovely responses from all of you. And I think we're going to need to close our program. So thank you, Dr. Deshmukh, for your time today. Thank you for this in-depth dive into our neurosurgical program. So just a couple of thoughts here. If you were inspired by today's presentation and you'd like to get involved and learn how you can help support Dr. Deshmukh's work, feel free to connect with our team. My information is on the screen and we'll be sending out a follow-up email in the coming weeks. And just thank you so much for making the time to be a part of today's presentation and for your interest in our program. Our next Doc Talk is going to be Tuesday, July 13th, and we'll feature the Providence Behavioral Health Program with a talk from Dr. Kara Johansson on maternity-related depression. We hope you'll join us again, and thank you so much for taking the time today. Have a great afternoon.
Thank you so much. Thanks, Dawn.
Thank you.